Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers and specialists come together to learn about high-risk pregnancy conditions, share experiences and work together to ensure the best health outcomes for mothers and babies. Today, we are learning about the identification, treatment and management of high-risk pregnancy condition, antepartum hemorrhage or APH in pregnancy. But first, let's meet our expert trainers.
Hello everyone. I am Dr. Karishma Tharyani, a senior obstetrician and gynecologist. As we all know, antepartum hemorrhage is bleeding from the birth canal after 24 weeks of pregnancy. It is one of the most dreaded obstetric emergencies, as any delay in its diagnosis or treatment can endanger the life of both the mother and the fetus. 30% of maternal deaths in India are because of antepartum hemorrhage, of which at least half can be prevented if only this condition is diagnosed and treated on time. So, it is of utmost importance to correctly diagnose and treat this condition. To help us understand the different causes of antepartum hemorrhage, its diagnosis and management, today we have with us Dr. Poonam. Dr. Poonam is a senior consultant maternal and fetal health at CFMC New Delhi. Welcome, Dr. Poonam.
Thank you, Dr. Karishma.
Dr. Poonam, what are the different causes of antepartum hemorrhage and how can we clinically evaluate a woman who presents to us with bleeding after 24 weeks of pregnancy?
So, as you rightly pointed out, Karishma, antepartum hemorrhage is a life-threatening emergency in obstetrics, and it is when the bleeding happens in a pregnant lady after 24 weeks of pregnancy. So, the most common causes are number 1, placenta previa, number 2, abruption of placenta, and number 3, ruptured uterus. So, I'll tell about these in details. It's very important to diagnose these conditions first on the basis of the clinical evaluation, which means history taking and examination. So, every woman who comes with bleeding should have the vitals checked, which is the pulse, blood pressure, oxygen, SATs, and this is very important because this will tell us as to what is the severity of the bleeding. Obviously, the amount of bleeding is also important. The history should be, is the bleeding continuous or does it come regularly, which means is it something which has been happening quite frequently, which happens in placenta previa. So, placenta previa usually would present with recurrent bleeding, can present with painless bleeding, and usually women would continue to have bleeding without understanding that there has been a bleed. In fact, it is noticed more often when the woman is sleeping. So, early morning time is the time when she would notice bleeding without having any indication like the pain. So, these women need to be taken to the hospital, and in the hospital an examination has to be done, and if the presenting part of the fetus is away from the cervix, it should give us an idea that there could be a placenta which is lower down, which is pushing the head up. As also we need to check the contour of the uterus and the height of the uterus. So, this is what placenta previa is, which means the low-lying placenta, the placenta which covers the internal os, and there are various gradings of placenta previa. The second, which is a life-threatening condition for the fetus and the maternal also, is what is called the abruption of placenta, where there is a bleeding which may be disproportionate to the actual problem that is happening. So, here the bleeding happens behind the placenta, can present as a revealed bleeding, but can also present with a bleeding which can stay at the back of the placenta. These women usually have pain with bleeding. There could be a history of trauma or high blood pressure, and if you examine the lady, the contour of the uterus looks quite hard. So, it's like a hard uterus which may be little above the normal level of the gestational age where the uterus should be. So, these women also are at more of a risk of having a fetal complication because, and that depends on the quantity of the bleed that has happened. So the fetal heart may be absent or present depending on how severe the blood loss is. The third reason why a woman can present with bleeding is the rupture uterus, where the woman has had some surgery in the past or a previous cesarean section, and this exposes the women, especially in labor, with more chances of dehiscing the scar, which is rupturing the scar wherever the scar has been. So it can happen due to previous, secondary to the previous cesarean section, or secondary to myomectomies, which is the removal of the fibroid where the incision has gone through and through. Now, women usually present with labor pains and a feeling of a pain at the level of the scar. On examination, it is important to understand that, that the contour of the uterus, the shape of the uterus is lost. More of fetal parts are felt, and there is a possibility that fetal heart is not heard. These kind of women needs an emergency admission and the further management. So these are three most common causes of the antepartum bleeding that can happen in pregnancy.
What is very important for the healthcare workers to remember is that there are three main causes of antepartum hemorrhage. That is the placenta previa, that is when the placenta itself is covering the os and the bleeding happens through from the placenta. Second is a placental abruption or detachment of the placenta, wherein the bleeding may be revealed or concealed behind the placenta. And third is the rupture uterus. We need to remember that for the diagnosis, or at least coming to a differential diagnosis of the cause of abruption, you don't really need any sophisticated measures. As Dr. Poonam explained to us, most of the times we can come to a differential diagnosis only on the basis of a well-taken history and a thoroughly done examination. So Dr. Poonam, you've told us about the pointers on history and examination. But like we've discussed, antepartum hemorrhage is an emergency. Please tell us what are the steps in the emergency management of a woman who presents with heavy bleeding to the healthcare worker.
When the women presents with heavy bleeding to the healthcare workers, the first and the foremost is to very quickly elucidate history from the patient or the people who have got the patient to the center. We have to watch the patient very carefully, understand that she is not drowsy or very irritable or perhaps in shock. The second important thing is to start thinking of how to manage it to the best of the capabilities wherever she is. So the first thing is, if there's a possibility of putting a cannula in, we should put the cannula in by a large bore cannula, which is 16 or 18, preferably on both the arms. And try to start using the Ringer's lactate, which should be 1 liter in 20 minutes. In the interim, we are watching the pulse, the blood pressure. Also, we need to keep an eye on the urine output. So a Foley's catheter, if possible, should be inserted with a hourly urine input and output. So output is important here. So input has to be documented. And then entire systemic examination as to what could be the cause of the bleeding needs to be ascertained, which is by feeling the uterus and feeling for any pain that is there or no pain, and adequate referral to the tertiary center after making a diagnosis out of the three that we have discussed.
Any tips on how to transport such a woman?
Once the healthcare workers has noticed the pulse, blood pressure and the vitals, including the history, it has to be documented on the card that the patient has, and then she makes arrangement for the transfer. So very important that the tertiary referral center should be aware of this patient coming to their center so that they are ready for her. The transport has to be arranged. The counseling of the patient and the attendants around her needs to be paramount as well, because they should be aware that this is a life-threatening condition. There is a very high risk of losing the patient and the baby if not corrected at the same time, and that's the reason why the delay in the transfer has to be avoided. While being transferred, if there is a healthcare worker who is equipped with the, putting a airway during the transfer or putting the fluids in, should be there with the patient in the ambulance while transferring. It is also important that if the anti-shock garments is available, that will help to maintain the blood flow to the vital organs in the patient. If possible, put the legs up, so elevation of the legs would help do the same, get the blood to the most vital organs. Monitoring while being transferred is also important, and documenting everything that is being done while during the transfer is important. Oxygen, is, if available, should be started at 6 to 8 liters per minute along with the fluid. And important thing is that the blood transfusion, the grouping and the cross matching and the bloods, if can be taken, should be done as well. As also the attendants needs to be aware that few healthy donors should accompany the patient should there be a need of the units of blood transfusion depending on the severity of the blood loss.
Thank you, Dr. Poonam, for explaining the emergency management in such a comprehensive way. What the healthcare workers need to remember is that promptness is the key. Now, it's not the time to do things in a stepwise manner. We have to start doing things simultaneously. While taking the history, the healthcare worker should also be able to assess the degree of blood loss that the patient has already had by checking her vitals, by looking at by clinically assessing the blood that has been lost. And once that assessment of blood loss has been done, the entire attention should be towards stabilizing the woman by means of starting oxygen, by keeping her warm, by starting her IV fluids, that is by putting a large bore IV cannula, depending on the resources that are available at that particular setting. Once the patient has been stabilized, the next thing comes is the counseling of the relatives. Once you write referral of a patient, sometimes the relatives may take a long time to take the patient to the tertiary level hospital. So it is very important to document all the patient's findings and simultaneously counsel the relatives about the emergent need to take her to the tertiary level hospital. At the same time, like Dr. Poonam said, the tertiary level hospital doctors should also be informed about this kind of a patient who is being transferred there, so that they can make arrangements by calling the specialist and notifying the other required staff to be there. So, Dr. Poonam, we just spoke about the emergency management and we talked about assessment of the amount of blood loss and classification of shock. So, can you please tell us what are the different classes in which the shock is classified based on the woman's symptoms?
So, the blood loss is classified as class 1, 2, 3 and 4, and this depends on the estimation of the blood loss that is there. So, class 1 is when the blood loss is felt to be less than a liter. The patient doesn't complain of any problems. The pulse, the blood pressure, all is within normal limits. Class 2 is when the pulse starts rising up more than 100, the blood pressure is well under control, it's normal, and the patient still remains to be okay. Class 3 is when the blood loss is estimated to be about 2 liters, and now the pulse is higher, which means the patient becomes more tachycardic. The blood pressure starts dropping, and now the patient starts feeling of restlessness, irritability, there's a pallor in the patient, and these patients need to be looked into rather at the urgent level. Class 4 is when it's life-threatening and has to be dealt as at the earliest possible with blood or with some fluids, at least to begin with. Here the blood loss is more than 2.5 liters. The blood pressure is dropped to as less than 70, so the patient is actually in the shock. The urine output can be 0 or less than 30 ml, which is a normal levels, and the patient has a air hunger, and these are the patients who need to be dealt with in an absolute emergency with fluids and blood at the earliest possible.
As Dr. Poonam just explained to us that hypovolemic shock because of blood loss is mainly classified into 4 different classes. And this classification can be done very easily on the basis of patient's symptoms and her examination findings like increase in her pulse rate and fall in her blood pressure. So, Dr. Poonam, you just told us about the different classes of shock. Does the emergency management given to the patient differ on the basis of the class of shock she belongs to, and if yes, then what are the, how do we differentiate or how do we manage the different classes of shock?
If the class 1 is the level of shock that the healthcare workers is dealing with, that is when the bleeding has probably stopped, as the blood loss is not that much. These are the women who can be dealt at the healthcare center. If there is a facility of a scan available, it's important to rule out whether it's a placenta previa. Occasionally, clot can also be seen, at the back of the placenta. So these are the patients where scan will give us an idea about placenta previa versus the abruption placenta. If the placenta is low-lying and the bleeding has stopped, these women can be kept in the follow-up in the healthcare center and looked after there. In case the bleeding is far more and it is manifesting as tachycardia or BP which is coming down, or there is an evidence that there is an abruption placenta happening which may need delivery depending on the gestational age, these are the women who need to be referred to the tertiary care center with adequate transfer facilities, as we already talked about earlier. Always remember that ABC is very important, which means airway, breathing, circulation. Circulation in the form of large bore cannula, size 16 or 18 on both the arms. Bloods, if possible, take the bloods for the hemoglobin, the clotting, and the grouping and the cross matching. Always to have some blood always ready, and especially the attendants, healthy ones, need to understand that, and counseling is equally important before transfer of these patients to the tertiary care center.
What we need to remember is that all women with antepartum hemorrhage need to be referred to a tertiary care setting. However, women with class 2, 3 or 4 level hemorrhage need to be referred urgently. Dr. Poonam, how are these women managed at the tertiary level settings?
So at the tertiary level settings, the foremost thing is to rapidly assess what is going on with the patient, which includes a thorough history taking quite quickly, and then examination of the patient with respect to the vitals and assessing the amount of the blood loss that has happened. Now, this would tell us as to what the management would be depending on the severity of the blood loss and the differential in the diagnosis, which we are thinking on with respect to the history taking, the examination, and if there has been an ultrasound done, we can come to one of the causes out of the 3 that we have been talking about. If the bleeding is not that much, the specialist can actually do a speculum examination to rule out the rarer causes of the bleeding during pregnancy, and then the management would depend again, as we said, on the severity of the blood loss. Now, if it is an antepartum hemorrhage due to placenta previa, where the placenta is low-lying, and this can be confirmed by the ultrasound if there is a time for it, which means the bleeding is not that much. However, if the bleeding is severe, it is term pregnancy, it is better to go and deliver the patient. Even if the bleeding is not there and it is a term pregnancy, there is a malpresentation which usually accompanies the low-lying placentas. It is important to deliver the patient by a cesarean section at that time. Otherwise, it may come as an emergency in the night time, which may be not a very conducive time for delivery. So, placenta previa, if found to be in the theatre, we can do what is called as a double setup, where if the placenta is not is lying low, but not as much as low, which is what we call as a mild variety of the placenta previa. Assessment can be done in the theatre with all plans to go for the surgery, and if the placenta edge is not seen while examining vaginally. These patients can be allowed a vaginal birth with an ARM and oxytocin, but with a very, very close monitoring that should there be further bleeding, they can be immediately taken off for cesarean section. Any excessive bleeding or bleeding which is much more than expected should straight away go for the cesarean section. In the second diagnosis, which is if the diagnosis is made of abruption placenta, then depends whether the baby has fetal distress or the severity of the bleeding. So if the bleeding is not severe and the baby is doing well, we can give a trial of labor, again with a very close monitoring, especially of the baby and the mother, and any evidence that the bleeding is increased or there is a fetal distress, there should be cesarean section which should be resorted to. Rupture uterus, we have to go straight for a laparotomy and deliver the baby and make sure it's confirmed rupture uterus and the necessary management done for it.
Thank you, Dr. Poonam, for simplifying the management of antepartum hemorrhage for us. What we need to remember is that operative delivery is the mainstay of delivery in women who are diagnosed to have placenta previa or rupture uterus, whereas patients diagnosed with abruptio placentae can have a vaginal delivery depending on the fetal and the maternal status. So this brings us to the end of today's session, and I would like to wholeheartedly thank Dr. Poonam for sparing her time and being with us here today. Thank you so much, Dr. Poonam, for simplifying the causes, diagnosis and management of antepartum hemorrhage with us.
Thank you, Karishma.
In the end, I would just like to highlight one very important fact again, that is 30% of maternal deaths in our country are caused by antepartum hemorrhage, out of which 50% are preventable if only this condition is diagnosed and treated on time. Diagnosis can even be made at low resource setting through a good history and a thorough examination. The key to management is promptness, understanding and assessing the degree of blood loss, stabilizing the patient, documentation and referring the patient timely to a higher level facility. By this, we can drastically bring down the morbidity and mortality caused due to antepartum hemorrhage. To know more about the details of diagnosis and management of antepartum hemorrhage, please have a look at our protocols.
That brings us to the end of this training session about the identification, management and treatment of antepartum hemorrhage or APH in pregnancy. Remember to refer to the high-risk pregnancy management protocol for more details.